Hi, it's Dr. Noel Williams, Optimal Health Associates, Oklahoma City, Oklahoma, August 12, 2021. I think I wish it was 2022, like all of us. So we're talking about COVID. So let's begin by saying we can all make it. We can all hang in there, whether you're just a person like me or a doctor or a kid. We're all going to make it. We're all going to be fine. This has been a very, very stressful month because we have been in shock and, to an extent, denial on some levels that this could reoccur. And again, it's the Delta variant. And I want everyone to realize that the Delta variant is like COVID plus or COVID 3. It's a true new mutation. If you look at kind of this antibody stuff and effects, I mean, we were looking at whether you were infected, and this is infected, prior infection data, and this is vaccination data prior to Delta onset. You basically had a 90% true immunity rate. You had a 9% chance of an asymptomatic infection, which basically gave you a functional immunity of 99%, and a 1% chance for mild symptomatic infection, with severe symptomatic infection being between 1 in 10,000 and 1 in a million, really, overall. Now, within that group, there's some immunocompromised people, but if you look at the average person in the United States, which is 95%, we're talking about. So that's how it was. Delta, with the antigenic change, has shifted that to roughly 35% to 40% of people who are vaccinated are immune still. 30% or so are asymptomatic if they get infected. And probably about 30% are symptomatic but mild, 1% are severe, and I'll round that up, a little bit less than that die. And what we're not seeing any difference so far with prior infected. I know that drives some people nuts and doctors nuts, but it's the truth, and it is what it is, and I can't stop being truthful. So but Delta changed everything, and with that change, we were kind of having to be reactive again. So the number one thing with being reactive is people get spastic, and people get angry, and people get frustrated, and if your loved one's sick and there's not as many hospital beds, it's hard on you like it's always been. So let's talk about hospital beds. Some people say, oh, there's not really a hospital beds shortage, there's a nursing shortage or a staff shortage. And that's really what's going on, but it doesn't matter because we aren't at the same level of hospitalization for COVID, but it's an extra 10 to 20% of bed space at the hospitals that they're not used to having. And the problem is all the hospitals have less beds because there's significantly less staff. Oklahoma has that a little worse because a lot of our nurses, and again, for very good reasons, if you're going to get paid 200% more by being a traveling nurse for 6 or 9 weeks, and then you can take 6 or 9 weeks off, or maybe even more than 200% than your average pay here to travel to New York or Minneapolis or wherever it is. We've lost staff, plus we've had retirements. We've had retirements with pulmonologists, nurses, respiratory therapists. So that limits bed space. But again, it's not about surgeries. It's those don't take up beds per se. I mean, yes, they're in for a day or two, but those aren't beds you'd use for COVID patients anyway. So the problem is the combination of COVID coming back with less staff gives us a bed shortage. So if you were watching the news in Oklahoma City, you would know that Mercy has no beds today or yesterday. Being on the COVID task force, the director here, I mean, the number of transfers at Mercy that they've said no to last week, I think was more than 500. OU was well more than 500. Integris was the same. I mean, all these transfers they normally would take for other things, let alone COVID, they can't take because they don't have the beds, and the beds are COVID and nursing shortage. And there's no solution to that. There's a million nurse shortage in the United States. We can't fix that this week or next week, but hopefully maybe we can over the next few years with some good public health leadership, which would be amazing. But that's kind of where we are with COVID. I think, again, vaccine saves lives. I've said it so much I can't even say it anymore. Vaccines save lives. Oh, let's talk about these two people. One guy's a from a virologist who may have been involved in the original messenger RNA vaccines, I can't remember his name, and the doctor who addressed the school board. The thing that's confusing about those guys is they speak truth and then falsehoods. It's a mix. And so the first thing to realize, there's no antibody-dependent enhancement. This vaccine was specifically designed for that from the very beginning to avoid it. That has not occurred. What has occurred is we have a different variant that the vaccine wasn't designed for because it's a true change. But the vaccine still works. The goal of the vaccine is to prevent serious illness and death. It is still a 99% reduction. That counts. It is not making the disease worse. It is not facilitating more cases. COVID-19 Delta variant is super infectious. It's 300% more sticky, and it reproduces at 23,500% more rapidly, so it makes it a troublesome little viral bug. And that is the problem, which is why mitigation strategies like masks, some people like Rand Paul have said are a waste. And I don't want to go down that rabbit hole, but let's be thoughtful for a second. If you're wearing an N95 mask, which I've worn in surgery for like 3 times because I couldn't stand it, if you wear that perfectly, yes, it's probably all day long, everywhere you go except outside, it's probably going to be helpful. But the reality is we don't have those. They still fail. If you cough, it's just not realistic to think mask wearing is going to have a significant impact. What will have a significant impact is getting vaccinated. Getting vaccinated is what will have a significant impact. I'm not making anyone get vaccinated. That isn't the point. But if you want to lower your risk for COVID and you can get vaccinated, get vaccinated. If you don't want to get vaccinated, live with the choice of that and the fact that you're going to probably get Delta. Not every time, clearly, but a lot of the time because it's super infectious. So Kim, your questions. I hope that all makes sense. It's, again, I'm not for mandating vaccines for everyone. I think people need to get the vaccine who are adults, but I just can't, from a civil liberties point of view, mandate them. That's my personal opinion. I think we just have to educate people and have people live with their consequences. And that means if you couldn't get vaccinated for whatever reason or won't get vaccinated for whatever reason, then you haven't been infected with documented antibodies, you have to understand there's consequences to that. And I feel bad. And for the people who can't get vaccinated, talk to your doctors about other strategies.
Well, I think based on the comments, one thing that people may be confused about is, so if they haven't been vaccinated or had or whatever, they get COVID and they get really sick and they have to go to the hospital, say 10 days in. Why can't they get ivermectin or any treatments like that day 10 when they're really sick?
Okay, so we're going to go back to the pathophysiology of COVID, which is fine. COVID is a viral infection. The viral infection initiation event, which is when you're reacting to the virus, you make inflammatory mediators to try to inactivate the virus that end up attacking you. COVID, because it releases bradykinin when it binds to, which is a hormonal mediator per se, however you want to put it, binds to the ACE2 receptor, causes a significant release of mediators that are pro-inflammatory like asthma. You then get the infectious mediators and it comes up gradually. So by day 7 to 10, which is when people are going to the hospital with Delta, those inflammatory mediators are sky high, and that's why the person's going to the hospital. They're not going to the hospital anymore because of the virus. They're going to the hospital because of the consequences of the virus. So that's why early treatment, if you believe in early treatment outpatient, which I do and hundreds of doctors do, and again, my experience with early outpatient treatment with a combination of antimalarials or whatever, plus steroids and antibiotics, has resulted in 7 admissions so far and somewhere between 600 plus, maybe 700 patients and no deaths. And some of those people who got admitted were way down. I mean, they were a good solid 7 days in when I started with them. But the thing that helped them as much as anything, if they were later, was the antibiotics and the steroids. So when you hit the hospital and you're already 7 to 10 days in, you need antibiotics and steroids. Ivermectin, Plaquenil isn't going to be the key solution anymore. It has limited use. That's where the data goes like that for them. I think the data in the first week is really great. I think the data in the second week goes way down, and I don't think that's the approach. The approach is antibiotics and steroids, which is why I think everybody who goes to a hospital who gets sent home who's pretty sick but not sick enough to get admitted should be sent home with steroids and antibiotics. But that's a separate subject. So once you're in the hospital because you're really sick, the virus isn't the problem. Your antibodies are kicking in and getting rid of it by day 12. And so day 7, 8, 9, 10, 11, you're getting going. And so what happens is you have to treat the inflammation and the secondary bacterial infections. And that isn't what those meds are for. So that's why you don't use them. Did that make sense? Mm-hmm. Yeah. Whereas if you're catching it in the first 3 days or 4 days of symptoms, there really could be, there's strong consideration, even though many smart people disagree with me and the literally hundreds of, if not thousands of other physicians who feel this way and all the medical literature that shows the mechanisms of action and the outcome data. But it's okay to have disagreements. And it's okay for us to write it because we're licensed medical professionals and they're FDA-approved drugs, which we're allowed to use any way we deem fit, which I've said a million times is in stone. And so anyone who says that we can't write them is wrong. They don't know what they're talking about. They've never been in the public health. They don't know public health law. They don't know FDA regulations. Sorry, I do. They're wrong. Anyway, but I'm not saying that again, I always just want to be clear. Not giving it to you in the hospital, you're too late. The way to avoid the hospital and avoid treatment is to get the vaccine. If you get the vaccine, you get a 99% reduction.
Okay. A couple of people, including one of our friends, was confused on if you've tested positive, why are you then showing that you have antibodies? So they're just not understanding what antibodies.
Okay, so when you get sick, your body's immune system, first you have your first part of your immunity, your innate immunity to fight things, and then you have your cell-mediated immunity, or adaptive immunity, where you make things to fight the virus. So your B lymphocytes produce, they're plasma cells, they turn into blah, 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 but they make antibodies eventually once they get about 7 days or so, and they'll start coming up, and you make antibodies to fight the virus or the infection. So you're going to get antibodies if you have a normal immune system, and we want you to get antibodies because they last and protect you, or if they don't last, it's okay because your B cells, as I've gone through 4,000 times and now 4,001, you go from reactive B cells to memory B cells to germinal B cells that keep the memory of how to make the antibody and the exposure if it happens again, which is why we have immunity from things. And the same thing happens with T cells. Antibodies take 3 days to reactivate. Natural killer T cells take 6 hours with re-exposure.
Okay. Why have you changed your mind about getting the shot?
I've never changed my mind about getting the shot. I think there's sometimes a misperception that I didn't have COVID. I got exposed to COVID a ton of times. And then when the vaccine came out, after assessing the medical literature, learning about it, reviewing everything there was to review available in the medical literature on messenger RNA vaccines, and a big thank you to Bill Bondurant, MD, and Carl Ruskowski, MD, and David Chansome, MD, and innumerable other people. I think the data strongly showed a benefit for the average adult in the United States. For me personally, it's very simple, and I answered this in a written form today. If I would have gotten COVID, I had a 30% of getting long-term lung damage if I had a mild infection. I had a 20% chance if I had a I had a 20% chance for a serious infection. Separate from that, within that group, half the time I would get hospitalized and 2% of the time I'd die. So for me, the 2% risk for dying, the 20% chance for serious infection and long-term damage, plus a 30% risk of long-term damage with just a mild infection, said, I think I'll do the vaccine because the vaccine looks safe, because I think your worst case scenario with serious adverse events from the vaccine, I mean, I think the FDA says it's 1 in 10,000, 20,000. I think that's total baloney. I think that's wrong. I think it's much more frequent. It's probably, I don't know, I'd say maybe 1 in 1,000, but 1 in 1,000 for something that's significant versus 50% for something significant, it's it's easy. And I'm healthy. If you're not healthy, the ratios all switch against you. But I mean, per the FDA and CDC, the ratio of infection or side effects is way lower than what I'm saying. But I just multiplied it by 2,000% because I figured they're probably off by that much. But it's still, the data is, I think, very clear for adults. That's why it gets confusing for kids, because if you're 15 and you have a 1 in 1,000, 1% chance of getting a significant illness with, and again, I'm just giving the statistics. If you have a 1 in 1,000 chance or 1 in 100 chance of getting a significant infection, if you're vaccinated and you don't get vaccinated and your risk is still less than 1%, how does the vaccine help you? I can't get my mind around that yet. I've looked and tried and discussed, but I just can't get my mind around it in terms, because the risks don't change. But there's risks to the vaccine for kids. I mean, like there is for everybody.
So would there be benefit, or why wouldn't there be in getting one Pfizer and one Moderna instead of two of the same?
Oh, I think there's not been a study on that. I'm sure that doing 1 and 1 could, I don't think it will improve anything, but it won't harm anything because they're very similar vaccines. But I mean, the standard is to get 2 of the same.
And then you kind of already answered this. If antibodies aren't showing, does that mean you're not immune?
No, but it could be a sign that you're not immune. So it gets convoluted. But no, there's tons of people without antibodies who are immune. That's been shown in multiple trials. The journal Science. I mean, I can't help the fact that Fauci won't admit this. I mean, or the FDA or the CDC. I don't know what to tell people about it. His own, as I've said before, Andrew Redd said there's immunity on the T cell side that has nothing to do with the antibodies. We know this, it's how it is. But it doesn't, so you may not have immunity, but you'd correlate it to how, if you got sick all the time already and you don't have any antibodies after either getting it or getting the vaccine, you probably don't have immunity.
Okay. Why is early treatment not just the standard of care? Why isn't there education from the government? Why isn't there TV commercials about what to do, how to prevent, what to do if you test positive? Why isn't that just the standard of care?
Because the federal government has decided that isn't appropriate. Period. End of story. And no umbrella medical organization in this country will go against the NIH or FDA or CDC.
Okay. Yeah, don't say too much on that one. You can't. Okay. I just tested positive. What should I do?
If you test positive for COVID, you would always do your zinc pulse. You'd want to try to get 50 milligrams in every hour or two to get to 200 milligrams. You'd want to pulse your fish oil and make sure that you're on 2 to 3 a day, or at least add a baby aspirin. You'd want to do your vitamin D. You'd want to do your multivitamin. You'd get some elderberry and go from there. Melatonin, sorry. Also, I'd like you all to have been on it already. If you are infected, you can call your primary care doctor or provider, PA, nurse practitioner, and ask for perhaps tell them you're sick and what are your options. Oh, you can get, if you're sick, the other thing, I'm such a dimwit sometimes, you can get the antibody infusion if you meet the criteria. We've had tons of people get it. It's worked very, very well. The current data in the Oklahoma City area is a 60% reduction in hospitalization. So your provider can refer you over to either Integris or perhaps Norman or perhaps Mercy. There's a form. We have them at our office. If you're in our practice, we will refer people for that. But the antibodies work really well. It's just a matter of, do you meet the criteria? And is it early enough? And so that's the other thing, as I'm rambling, is that's why it's important to call right away, because you have to get the antibodies within, depending on what the doctors are feeling, preferentially between 5 and 7 days, maybe 8 to 10, they'll be flexible, but really within the first 7 days.
Okay, so I've been exposed to someone who tested positive, but I feel fine. Should I still follow the zinc protocol?
Yes. If you get exposed, I would do the zinc protocol because you don't want to get infected, because it will limit or decrease your risk, in my opinion.
Okay, I've been exposed. I feel fine. Should I get tested?
If you feel fine, I don't think there's a lot of reason to get tested.
Okay. For people that had COVID, probably had COVID early on, like way back when it first started, but we weren't really sure and the testing wasn't necessarily here, would they still have the antibodies showing on testing?
Some will, some won't. Some will, some won't. If you're in the group that if you have low levels still, or normal levels, because I've seen both, no, your immune system got trained. It doesn't mean you're totally immune, but again, immunity is different. We look at immunity to mean than what people perceive, that you're going to have some protection from serious illness. It doesn't mean you're immune every time. You could be, but you may not be. We want you to have, with the vaccine or a prior infection, we want to feel comfortable that you have a 99% reduction in serious illness.
Why are people with antibodies testing positive now?
Because Delta is different. So if you have an antibody that's this way, and it would normally match on the spike protein like this, but the spike protein is that way, so it's not quite matching enough to inactivate it, because Delta's changed. It doesn't have the same binding. It's like they changed the place in the puzzle where you put the puzzle pieces slightly so they don't fit. And that's the problem with mutations, and it's what we've been worried about, and it happened. So you get, some people still have full immunity, some people are asymptomatic, and some people have mild infections, but the mild infection rate's higher, which is not antibody-dependent enhancement. It still means the vaccine works because you're not getting super sick, you're not dying, but yeah, there's some of that.
And lastly, does the BAM infusion work for Delta?
We have had a couple people do it, and it seemed to help. In our COVID task force meeting, we talked about it, and they are still having good success with the BAM infusions. Because it's the same basic antibody that people who have the vaccine or the prior infection have, and they're running about a 99% effective rate of protection from those things, so the BAM infusion is working about the same. So that's it. Good night. Stay calm. Sorry this was long. Bye.